Okay, hello all. Welcome all of you to the Q&A session today. Uh, so let me start by introducing myself. I am Kiran Bali. I am located in Mannheim, Germany. I'm a experimental scientist working in mechanisms leading to chronic pain in preclinical and clinical pain models. So I'm associated with EFIC as a research projects advisor. So it's my pleasure to meet all the panelists here today. And yeah, so shall we start a roundtable of introducing your work and your selves? Maybe may I start with Louis to start with? Hi.
Let's
Yes.
go.
Yeah. Would you mind introducing yourself and your work? Yes, Luis, can you hear me?
Yes, I'm hearing you, but I don't hear any other question.
No, I mean, so let's start by introducing each of us. So if you
Okay.
can start by introducing
Okay,
yourself and
sure.
your work, yeah.
Luis Garcia Larrea. So I'm a clinical neurophysiologist, a neurologist, and working on pain and cognitive science. And I was with Daniel Ciampi in Valencia, giving talks about the assessment of chronic pain patients. And my talk was on instrumental assessment, or essentially electrophysiological assessment. I think that I did not do anything about imaging. It was just electrophysiology. So I just waiting for a question, if any.
That's perfect. Yeah. So let's go in the anti-clockwise, what I'm saying. So Daniel, can I ask you to introduce yourself? Yeah.
I'm a clinical neurologist, associate prof here in Aalborg University in Denmark, interested in clinical assessment of patients with pain, questionnaires, clinical phenotyping, and that's the main topic related to this presentation, and also interested in cortical physiology or neuromodulation in chronic pain, neuropathic pain in particular. Yeah.
Thank you. And Dimitri?
Hi, I'm a health psychologist. I do a lot of research in the context of cognitive biases for pain, on pain. But for this, for this conference in Valencia as well, I also presented some research on content validity, on how to move from a construct that we want to assess to assessment itself, and how to get lost, how not to get lost actually in translation. So indeed, making sure that we assess what we want to assess. So yeah, thanks.
Perfect. Thank you so much. So let me give a quick housekeeping for the participants. So all the participants, please feel free to type in your questions in the question answers box you see there. In case you would like to, you can also answer your question anonymously. So feel free to answer any question you may have, and I would love to keep it more interactive webinar with questions and answers discussion. So let me start my maybe so I attended all the sessions, all the sessions by the panelists. So let me start with very maybe basic question, right? So about the nociplastic pain. So being in the pain field for several years, so we all know this is relatively new definition introduced by IASP. So I also see that there are some different opinions about this, right? So I would like to have your take. I mean, how are you? How is it helping treat the patients? This having this new definition and about this. Luis, maybe may I start with you? What do you think about this?
Shall I start?
Yes, please. Yeah.
We don't know to what extent it will be helpful for the patients. I think that it definitely will be helpful in the sense that it puts a name that seems something medical, something real, with terms that are barely understandable for what was considered before functional pain. So pain for which you did not have any lesion or any reason medical to consider as an explanation, of an organic explanation. So even if you insisted as a clinician that this was real pain, that we did not have exactly a cause, but it did not mean that you did not believe in this pain. Well, this was always more or less fuzzy, in this sense that the term functional has been associated with non-organic or psychological things that the patient did not like very much. So now, in this sense, the patient feels entitled to have a real pain with a real name and medical grounds. So now, this is perhaps useful in a societal point of view. From the purely physiological or neurophysiological point of view, I'm not sure that we have done a big advance, because the notion of nociplastic pain stands very hard on a basis that is called central sensitization. And central sensitization is a neurophysiological concept that can be demonstrated in animal models, but very, very rarely in human beings. So we stand on something that is relatively fuzzy too. So we can explain that the patients that there is probably some kind of overexcitation of the central nervous system started by a barrage of peripheral input, and they understand, but we are not completely sure that this is explaining everything. I'm almost sure that this does not explain everything in nociplastic pain.
Yeah, sure. Daniel, would you like to add something?
Yeah, I agree. I think it's two different things. One is just like Luis mentioned, one is the patient's perspective. We need to ask them. The global impression is that people, when they have a name for something, that it's not hardware related, it's related to software. They say, oh, my MRI is said to be normal, but I still have low back pain. I have a non-specific low back pain, or I have fibromyalgia, even though my brain is normal structurally. I think it helps in general. It decreases anxiety, and it's just like depression. When you have someone who has depression and they understand that they have something that it's not affecting structurally their brain, but they still have something called major depression, I think it's globally fine to have a name and have a prognosis. And so name nociplastic, it's interesting clinically, but the phenomenon, the clinical phenomenon has been there forever. People who don't have musculoskeletal pain, people who don't have neuropathy or lesion to the somatosensory system and have a disease or pain type that is unrelated to any structural or identifiable somatosensory or somatic lesion. Then the issue, and then it's a very interesting point, because then it's a mechanistic. So that's a clinical issue, but then we have a mechanistic description that, as Luis mentioned, we don't know the mechanisms. So it would be super interesting to have something called nociplastic pain or dysfunctional pain described clinically, because it could only be right, because you can always describe something clinically. That's the way medicine works, right? You describe the clinic and then you figure out the mechanisms. The only thing that is very challenging for me is that there is something clinically relevant in terms of phenotyping, but then the definition is mechanistical, which is very hard because we don't know a lot about the mechanisms. So that creates a lot of confusion in language and the way we communicate and think. Some people don't like nociplastic, the name, but agree on the concept. Some people don't agree on the concept from the mechanistic perspective, but agree on the clinical perspective. I think there's a language issue.
Yeah. Before I continue the next question, Dimitri, would you like to add something to that?
No, I think I follow this reasoning. I think it's indeed it's about language. It's about yeah, well said. But what I wonder actually is whether it will really have an impact also. For example, on stigma. Do you think this will impact on stigma? Because if you know put a name on it, will it reduce stigma?
There might be, I don't know if my colleagues agree with that, this might be an additional impact, is that beforehand, to escape from this notion of functional pain, there was sometimes a struggle to call, for example, fibromyalgia, which is the paradigm of nociplastic pain, to call it neuropathic or pseudo-neuropathic pain. So now it has a name, so you don't have to spend your time explaining why fibromyalgia is not a neuropathic pain. So the fact, okay, we are playing with names, but perhaps it's interesting to have a name, even if within this name, we are not putting all exactly the same thing, but we have things where we are all more or less in agreement, is that in general, this type of nociplastic pain starts with a kind of painful barrage that does not end, and that little by little, the system cracks, and the system is unable to cope with this that is coming, and then it chronifies it. Then some of us can explain it or try to explain it by the neurophysiological mechanism in the dorsal horn with hypersensitization, etc. Other people can explain or try to explain by the unsuccessful descending control from the brainstem. Other will say, no, it's the cortex that is not controlling correctly. Okay, then the mechanistic explanation will change. But we are not struggling anymore to say this is not neuropathic, because this is not neuropathic.
Yeah. So as Daniel put it, so this clinical phenomenon was there. It was there for forever, but we have new name for that. So that actually leads me to my next question. So imagine now a patient comes and now we diagnose him with nociplastic pain. And what would be the like first line of action? Do we have any clinical or medical recommendations for that, or how do we handle this?
Myself, I I think it helps to open a window of possibilities of diagnosis, but I don't see nociplastic pain having a treatment in general. I think there will be names. What type of nociplastic pain? Fibromyalgia. The way nociplastic pain is defined, all the primary headaches would say, even though we don't say this, and we usually don't put that into the same bag, but in theory, all the primary headaches from migraine to tension type would fit nociplastic pain, most of the non-specific low back pains. So I don't think nociplastic pain per se, we're going to say, oh, we have a guideline for all the nociplastic pains, as we kind of have for neuropathic pain, which is a little bit different, even though there are nuances and differences. I think that the important thing is like, it's like a syndrome to my eyes. You open the possibilities of differential diagnosis, but you don't think it's neuropathic. You don't think it's a musculoskeletal pain. The prolapse in the spinal cord doesn't matter anything. You don't care about it. You're going to look at nociplastic differential diagnosis. That's the way I see it.
Perfect. Yeah. So I see a question from one of the attendees. So let me read it out for you. It is not somewhat misleading with regard to nociplastic pain to just focus on central sensitization or to use these terms almost synonymously? Can impaired inhibition not also be the leading mechanism? I think the attendee is talking about descending inhibition. Yeah. So, yeah, Luis, yeah, please.
Yes.
Please go ahead.
Yes, most probably the mechanisms that are underlying what we call nociplastic pain are multiple. And even when we speak about central sensitization as a whole, this hyperreactivity of the central nervous system obeys also to unsuccessful descending inhibition. So when we are speaking about excessive ascending input to the brain, this may be the result of both an amplification, subcortical amplification, but can also be fostered by the absence of the lack of descending inhibition. And on top of this, we have cortical, supraspinal, very much sophisticated mechanisms is what we call the cerebral cortex, and as Dimitri will be able to elaborate this more than me, but the brain is a very complex machine that is able to amplify the pain, to control the pain, to modulate the pain, and is no doubt also participating in this nociplastic symptoms. So the mechanisms are multiple, and when we say just hypersensitization, we are just not doing a mechanistic work. We are doing a kind of umbrella work that may obey to the convergence of multiple mechanisms.
Perfect. Thank you, Luis.
I think that Dimitri should be able to elaborate on the cortical part of this.
I think you explained very well, but indeed you have both. You have the top-down and bottom-up factors all playing a role at the same time. So you have a lot of factors playing a role, like top-down factors playing a role at the same time, and also in this like anxiety and all these factors do play a role as well. So it's important to also take this into account. So I agree on that. So I think you were referring to that, Luis, or not?
Daniel, you wanted to add something?
Oh, I agree. We don't know the mechanism. There could be anything. Also, because central sensitization can be present in any other type of pain, neuropathic pain, or it's. But then,
there's also a lot of discussion about what is central sensitization. There's what's in a name. I mean, there's a lot of things falling under the umbrella of central sensitization. So I think there was a recent review also, in which Ryckeghem and Johan Lyon were involved also on what is in the name of central sensitization. So it's it's quite difficult to grasp, I think.
But something that is very interesting for me is that this type of nociplastic pains may manifest at very different levels. So you call nociplastic pain fibromyalgia, but you can also nociplastic pain irritable bowel syndrome, IBS, for example, which does not refer to the same presentation. Clinically, they are very different. Tension type headache, many different types of pain can under this umbrella, which make me think that what each person has systems that are more resistant than others. And so some of us are perhaps better constructed to develop visceral pain than to develop somatic pain. And others are particularly prone to develop a tension headache. So this is something that may manifest, and this might be idiosyncratic. The fact that you develop this or other type of nociplastic pain may depend on your own disposition for that, which might be genetic or just epigenetic or whatever. But not everyone is able to develop the same type of nociplastic pain.
Interesting. I also like there's a proposal. It's just an idea framework that Professor Andrade presented in Toronto and published a paper that maybe because we know about central sensitization mainly happening in the spinal cord level, right, from animal studies. Further we go up to the cortex, less we know about the processes of central sensitization in particular. Maybe there is also a level where it's mainly occurring. And maybe there is a qualitative flavors of sensitization, maybe one more spinal cord, more brainstem, and maybe more cortical or thalamocortical. It's not really been explored, this idea, but I think it's very attractive as a framework to maybe nociplastic pain is something where central sensitization or the mechanisms, whatever they are happening more in thalamocortical, cortical areas. That's why sometimes we see in these patients so many traits of mood problems more intensely or more affecting other networks that are also presenting these diseases when you compare to someone who has a nerve lesion and electric shock likes, or someone who has a trigeminal neuralgia. And after you treat the person, they are normal and behaviorally. So it doesn't seems like maybe there's also this component that it could be tested. This, yeah.
Perfect. Thank you so much. So let me, so yeah, we have discussed enough about the nociplastic pain. So I would like to now draw your attention to another, another umbrella topic maybe. So because this lecture was about assessment of pain, and it involved all the electrophysiological methods to assess pain in individual patients and so on. So I was wondering about, I mean, I know we are still not there, but what are your thoughts about having kind of objective molecular marker, non-invasive marker, or less invasive blood test for neuropathic pain, for example? I mean, I know there was one recent publication about the serum marker for the neurofilament 200, I guess, elevated levels of that indicative of neuropathic pain. So what do you think from your experience? Have you ever came across such experience or studies?
We are, and we particularly when we're doing neurophysiology or functional imaging, we spend much time looking for biomarkers. But pain is a subjective experience that can change from 1 minute to another. If you had a serum marker of pain, this serum marker should be able to change in some milliseconds, because you can be experiencing excruciating pain, and then someone tells you something that interests you most, and you forgot this pain. So pain is something that is continuously evolving. It's something that is generated in your brain. So I do not believe that we will be able to have something static that is able. What we can have is a biomarker of a disease or a state that can produce this pain, and that authentifies the fact that you have the right to have this type of pain because you have this biomarker. Then it's already possible in neuropathic pain to ascertain the existence of a lesion or disease of the nervous system. This is now possible. You can do this. In some instances, you can also objectify the provoked pain, allodynia or hyperalgesia, because we have markers that can change very rapidly. For example, pupil dilation or skin response. These can change very rapidly, and they cover with your arousal reaction to pain. So if someone tells you I have an allodynia and you brush the skin, it's ay, 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 but it's not only ay, 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 but you have a vegetative reaction immediately with the ay, 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 you know that this is an objective marker that something has happened that evoked arousal. So these type of markers are available, but a marker of pain in itself, ongoing pain, I personally do not believe in that. Perhaps my colleagues do.
No, I totally agree with what you say. I think, well, pain is something subjective as such. It's not something you can objectively measure. And even with the arousal, I would be surprised because, yeah, anxiety could also increase your arousal already. So, I mean, again, it's not a direct measure. Also, your ideation, your skin conductance. I mean, if I'm getting more anxious, well, this will fluctuate. So also that is not, and there's not a one-to-one relationship between anxiety and pain experience. There are a lot of other factors playing a role. So it will never be a direct measure of pain experience. I think that's something like that is probably impossible to have an objective marker of.
Yeah, but we have a very good marker of pain. Not objective, but it's self-report and behavior.
But
when we just
I agree. I think
it's implicit when you start to talk about biomarkers that we want something that is objective, and then we can ask, well, how can something that is based on the subject not be subjective? I would rather have subjectivity because it's on the subject to tell you, and maybe it's Yeah, maybe it's a quest for something that is by definition not objective, because
Non-existent.
coming from the observer.
And one could discuss what is objective and subjective as well. I mean, why is a self-report not objective? I mean,
Yeah,
You have perhaps two levels, if I can push a bit the cork in the bottle. Two levels to discuss this. One is when we are in a diagnostic process of, let's say, normal patient who is able to tell you where is the pain and how is the pain, etc., and then you must believe him. Then when we are struggling is to have markers of something in the nervous system that can explain this pain. A lesion, a disease, a strain, an inflammation, whatever. Okay, this is the first level, and then we can, of course, at the end say, okay, this is purely subjective. So I'm finding the lesion, the reason why, but not the pain itself. But then we have another level when the patient is not able to express, to talk. When you have a patient with dementia, or a patient in coma or in vegetative state, or an infant, someone in neonate, and then also our colleagues, clinicians doing this, need to know, to have some glimpse of whether reasonably there is pain. And then is where the biomarkers, even if they are imperfect, they get all their importance, because it's very important to know that the pupil is dilating or the skin is responding when you are mobilizing a patient in the intensive care unit, because you know that you are stressing this patient. So is this the same pain as we can tell? Perhaps not. But in these particular cases, the thing is, it's very important to think about these biomarkers.
But then you're more talking about stress than pain, or not? I mean, it's a biomarker for stress. It's a biomarker for arousal, not per se for pain.
But pain entails arousal. So by the arousal, you could, if this arousal is strictly provoked by a maneuver, if the arousal is controlled because you are just changing the position of the hand, you can reasonably consider that this is unpleasant for this patient. And in this case, I mean, we are not anymore doing research. We are before a patient who may be suffering. So even if we are not completely sure, I think that we could take this for granted. Okay, by default, I'm doing pain.
Yeah.
Yeah, I mean, if I can add a little point there. So also having an objective measure to track the response to treatment, right? Where one can actually reduce or increase the dosage, right? Maybe there having a objective measurement will help, right?
Yeah.
So perfect. So then, so maybe if I can request all the participants, please feel free to type in your questions in the question and answer section in the chat or in the somewhere. We look forward. We are very happy to have your questions, feedback here, right? So then let me then, meanwhile, waiting for the questions from the participants. So let me go ahead with the next question. So Luis, you mentioned about segregation of the patient population, right? Based on their background, right? Background questionnaire and so on. So you, as you rightly mentioned, when the patient is in trauma, in suffering, having this background questionnaire, collecting them and so on might not have any use, right? But I mean, how do you see that in the context of like a bigger trials? If the medication, right, a drug that went to like a phase 2, phase 3, then that maybe that failed. So do you think having such a background validated questions and then segregating population respondents and non-respondents there might be useful? Or what do you think about that?
I'm not completely sure to have fully understand your question, but if you are targeting the fact that the response to some drugs may help you to understand the mechanistic context of the pain, then I think that the response is right, in at least in some instances.
Mm-hmm.
If you are changing drastically the pain of a patient with an anti-inflammatory drug, you may reasonably consider that there is some inflammation going there. If the anti-inflammatory is not working, this also orients you. Even within the, let's say, anti-neuropathic drugs, we know that some of the drugs are acting more on the hyperexcitation in dorsal horn or in the thalamus or in the cortex, and other drugs are more active on descending inhibition, for example, like there's the classical differentiation between the so-called antidepressants and so-called anti-epileptics. So in some instances, you can also use the response to drugs to have some working hypothesis about the mechanism. But I insist in some cases, because things are really not very clear-cut. And for some patients, you may have the impression, for many reasons, that there is hyperexcitation going on, but they are going to respond very more to a drug that is not actively, in animals at least, acting on this mechanism. So it's a bit fuzzy, but fortunately, in some cases, it can orient you.
Okay. Daniel, you wanted
What
to
do you
say
say, guys?
It's super interesting, because clinically we end up trying to do this and adapt, and you have this perception that this type of patient may respond to this type of drug. But it's so complex, because then we have the time effect, and we don't know if someone who has a certain profile will have that profile forever. As Luis mentioned, it's so dynamic. So maybe I have someone with a certain phenotype, whatever phenotype means, a certain profile in a questionnaire, a certain profile in QST, a certain profile in the EEG, and then I may target that. But then the person, do we migrate profile? Can I be profile A and become B after 6 months or after treatment? We don't know. We don't know if I have a certain profile and that it's my profile, and then you target my profile. Would the other symptoms that I have, which are not in this profile, become the most important symptoms? Sometimes you have patients who have burning pain, and you give a drug, they come back and they say, I don't have any burning pain, but now I'm being bothered by my paroxysmal pain. So the paroxysmal pain was there, the burning pain was the most important, and then it was treated by a drug, but then they had another component that became the main actor. So I think it's super interesting and clinical relevant to go in this way, but it's just a Pandora box, because when you put time into the equation, it can become more complex.
Yeah, we all have examples of this, but what Daniel is saying makes me think about one patient I saw last year, who had a very clear neuropathic pain in the legs due to a connectivopathy with a Sjögren syndrome, which is connectivitis, something that is very well known, that is able to attack the nerves, so that it gives you a classical small fiber neuropathy with pain. And this patient was telling me that one day he had gone up and have pain in the legs that was completely different. They say, I knew that it was not the same pain, and it was something that it was more deep, and it was not the neuropathy, and little by little, he developed a very classic fibromyalgia syndrome, which is something that we see in these patients, that they can go from a neuropathic state, and then after being submitted to this continuous neurogenic pain, they develop another type of pain, as if the system had broken down. All the system that it had to react against this had crashed, and then the pain flares, and they feel that it's not the same pain. So what say that Daniel is very important. Things are continuously evolving. So okay, to phenotype, we are going all phenotyping. We are all phenotypers, but the phenotype can change over time.
Yeah, perfect. Yeah, very well put. Thank you so much. So, Dimitri, if I can ask you one question concerning, so you very well explained about this discriminant content validity, right? So validation of the in a questionnaire with the context, right? What's happening. So yeah, you also very well explained about the pain catastrophizing scale. So how it can be basically ill understood, right, if it is not treated well. So such phenomenon can also can also come up with valid terms. What should be included in such questionnaires? What do you think?
Yeah, it's a shift in topic now. So my presentation actually was more about okay, do we measure what we want to measure? And the example I gave was mainly about pain catastrophizing, which has been found to be one of the best predictors of chronification of pain, of chronic pain, and so on.
I think we lost Dimitri, right? Hello?
Yes, we lost him.
Okay, so while waiting, Dimitri, come back, let's take a question from Teresa Lapa. So let me read it out for you. In my opinion, emotional and cognitive components amplify nociceptive and neuropathic pain. So I think it's more like a comment. Do you want to add anything, Alois?
Dan?
Daniel?
Sorry, I was muted. It's like a revenge of Zoom. Teresa, I agree. I think mood can amplify everything, from inflammation to pain to symptoms. It's a big amplifier, just like sleep deprivation, just like many other things. We have these non-specific amplifiers that amplify bad stuff. So I agree.
Yeah. So Daniel, maybe then I can ask you. So you mentioned very shortly about this, how is it called, segmental alterations, right? Unilateral pain conditions, like in post this PHN. So this unilateral alterations. So I mean, it was just it caught my attention. Would you be able to would you be willing to elaborate a bit more on that?
Oh, about unilateral pain?
Exactly, unilateral pain conditions. And so you mentioned the segmental alterations will be different in unilateral pain conditions when compared to regular pain conditions, right? Unilateral neuropathy conditions. I mean, in general about this, yeah, how this can be measured in clinic, or how do you handle that? Yeah.
Well, I think this is a part of the Valencia. It's been a while, but I remember the presentation. I think it's a moment where we talk about referred pain, I guess, if I'm not mistaken. So the point was that any structure below the skin, we usually talk about muscles, but it can be fascia, it can be bone, it can be periosteum, it can be ligaments, it can be joints. We usually don't know where our joints are, where our muscles are. We know where the skin is. You have something that primarily affects your deltoid muscle or your ligament in the shoulder. It's very often that we experience pain away and we have referred pain. We learn referred pain usually when we talk about visceral diseases, but it's not specific for viscera. It's for everything that is not innervated by discriminative A beta fibers. So usually basically everything under the skin and mucosa. And that I think it's very relevant because one, pain is not felt where you have the disease, and that can lead to, but it's super long known for ages, right? But it's very classic because sometimes when our colleagues who are not pain specialists, they don't know it. Sometimes it's very not so rare to work with oncologists who have a patient with knee pain and they come with a lot of MRIs, which is natural. They have cancer and they could be metastasis. Then they have something in the joint, in the hip joint, not in the knee, but it's a referred pain, or someone with arm pain that has a problem on the shoulder, to cite an example. And the interesting thing is that if you examine these patients, it's very common to find mechanical hyperalgesia, not deficit. It's not so common to find deficits. So this is very easily confused. Imagine a patient who has some spinal, some prolapses of the intervertebral disc, which is super common in the general population. And then they have pain in the shoulder with referred pain to the arm. And then they have hyperalgesia if you examine them. It's not a deficit, it's not a neuropathy, but it can be confused with something like a radiculopathy. And if we're talking about the spinal cord to the lower back, to the same phenomenon in the lower limbs, like spinal, it may be misinterpreted as root compression, even though you don't have deficits, even though it's not a radiculopathy. So the idea was to highlight this because it's so common to have, and then it's called pseudo-radicular or several other names, and we just have to highlight that. I was mentioning to that it's relatively common, and for some reason we know the classical descriptions, but we don't study that, as even though it's much more common than radiculopathy, we don't study that often this phenomena. There are some groups who have done a huge amount of work, but in specific time points we don't have a continuous, at least from the clinical perspective, exploration of all these referred pain patterns. For example, we don't have a lot of atlases of anything that is not muscle or fascia, for example. We don't have referred pain patterns from joints, for example. We have for muscles based on saline at 3% injection, but not really the other structures beyond muscles. That was just a comment about this. And you may have this, if it happens in the neck, you will have referred pain to the head, and then it becomes a type of headache officially. So, and it can cause a lot of confusion. But that was just the point that I wanted to highlight in the presentation.
Great. Thank you very much for clarifying that. So I see, Dimitri, great that you came back. So before coming back to that, let's take the question from the attendee, one of these questions. So
Yeah,
what is
apologies.
no worries.
Yeah.
No worries. What is the current value of questionnaires with regard to the diagnosis of central sensitization, such as the CSI?
Well, okay, I will actually explain something else when I left, but if you want to go to the CSI, well, you have the Central Sensitization Inventory indeed. So this is a questionnaire that has been used. And we actually, well, we did a content validity. We also tested content validity of the CSI, as we did. I presented on pain catastrophizing, and recently we did the same with the Central Sensitization Inventory. And what you actually see with this inventory is it actually measures, well, constructs like depression, anxiety, all these constructs which are related to central sensitization, but it does not at all measure central sensitization as it's actually as a definition of central sensitization is done. So it measures all related constructs, and you could actually easily say, okay, I replace the CSI by using questionnaires assessing anxiety, depression, and of course, a lot of people with chronic pain will score very high on these because they have all this kind of symptoms as well. So it's actually a mixture of all things put together, and adding to that, what you see of the central sensitization inventory, if you look and you compare it with objective measures of central sensitization, or the so-known objective measure of central sensitization, you see that it often does not relate at all. You do not see that there's a correlation between this most of the time. So unless the colleagues see it otherwise, that's at least what I've seen in the literature. So I'm not sure about, for example, the questionnaire that currently is being used to assess central sensitization, whether that's a good measure or not. To be honest, I think it's more like adding a lot of symptoms together, on which chronic pain patients score high, and as such, people score very high on the central sensitization inventory.
Yeah. I think that there is a very clear dichotomy in the way we use the same term. First, when we are doing animal models and animal studies, and we are dealing with humans. when you read the literature on animal models and central sensitization, and in all cases, they are referring to something that has been exploding and increased before arriving to the brain. So they are referring, they may be by descending inhibition or ascending excitation, but everything is going to the brain already excited. When we are speaking about sensitization in humans, we also include the brain. I mean, many colleagues will consider that a state of anxiety or depression can contribute to this sensitization, but it's a purely cortical mechanism, which is totally different to what we are speaking about in animals. So at one moment or another, we should be putting it together and saying, okay, what are we speaking about in every case? Because now it's still some fuzzy things there.
Well, one can actually wonder whether you can assess central sensitization with a questionnaire. I don't think so, at least not the mechanistic idea of central sensitization. You might see some outcomes of it, like increased level of depression, increased level of anxiety, all these other related symptoms. But central sensitization as such, I think it's impossible to assess that with a questionnaire.
There are ways and experimental ways in humans that can mimic this. I think that they are relevant. For example, the nociceptive spinal reflexes. When you do it at a regular rate, you can establish norms of how big is the amplification, and you say, okay, this amplification is still normal, and then you may have an enormous amplification, and this is abnormal. So this is complex to do in patients, but this is a system that exists. Also, you can use in selected patients the secondary hyperalgesia, and it's very clear sometimes in headaches when you start having a pain from a teeth, from teeth, and you have a very localized with peripheral sensitization, and then little by little you are also having sensitization in other trigeminal branches. This is an indication that the central nervous system is responding abnormally. But these are particular features that are very useful in some of the patients. They do not exist or are not amenable to examine others.
Yeah, but I agree, but that's something else than assessing a questionnaire, of course. It's something very different than trying to assess central sensitization using a questionnaire. And I think if you look at the questionnaire that has been used to assess central sensitization, it's not assessing central sensitization as the construct is actually defined. It's assessing symptoms. It's assessing related things. And in that way, one can wonder about what is the added value of having a questionnaire that assesses depression, anxiety, all these different constructs, and adds them all together and says, if you score high on this, well, then you have central sensitization. Well, that might not be true. I think a lot of chronic pain patients or a lot of other people might score high on it, but do not per se have central sensitization. So I think it's important to make this distinction. And therefore, it's important to be clear about what a construct is actually, what is a construct and how we measure this construct. And I think there's a big differentiation between assessment here and construct definition.
Yes.
You were speaking about construct validity before when your computer
Exactly, yeah.
Could you sure, because it was interesting.
No, actually, I was talking about content validity in the context of pain catastrophizing. And what you saw, what I was discussing, and that's also what we did with central sensitization inventory. But what we saw, for example, with catastrophizing is that we have a lot of, well, it's probably, catastrophizing has been suggested to be one of the most important predictors of chronic pain. So it's, and if you then look at all the questionnaires that measure pain catastrophizing, what we actually saw is that a lot of items do not measure pain catastrophizing. They measure pain worrying or they measure distress, but they do not measure pain catastrophizing as the construct is actually defined. The construct is defined as an exaggerated negative state during experience of painful experience. So it's this exaggeration, and that's, for example, not something you can capture with a questionnaire, and that actually relates to what I was discussing before as well. If you cannot capture everything with a questionnaire, therefore you, for example, in the pain catastrophizing, you need context, and this context you cannot capture in a questionnaire. You can ask how do you think about pain, and how do you usually cope with pain or deal with pain, but you cannot take into account context. So probably you cannot assess pain catastrophizing with the questionnaire. And what we saw there, for example, is that a lot of these items measure pain worrying. And therefore, I think it's really important that if you want to assess a construct, or if you want to assess, that we need to be clear about the construct definition and how these items relate to this construct definition. And if our items do not capture our construct definition, well, then maybe we should rethink our construct. Maybe we are not assessing, for example, pain catastrophizing, but we are assessing pain worrying. So I think we should be very clear about that. And the same as is, for example, with the central sensitization inventory. We should be clear, what are we capturing?
Exactly. Yeah, that's
At least
very
that was
interesting.
more or less the talk.
Sure, yeah. I mean, that's very interesting. Maybe, yeah. So actually, we also have something like that for each, right? Each catastrophizing scale in humans, what like patient reported. So after attending your lecture, so many things now became like opened up for me. But now I'm thinking now, like point A to B, what you said, very valid. But if I wanted to come point B to A, if I wanted to have a valid construct to measure real pain or real itch in this case. So can your studies, maybe then do you recommend to have real mechanistic studies to define such valid constructs? How do we have?
I'm not
I think
sure.
it was clear that we cannot measure real pain. This
Okay.
is not measurable.
Yeah.
I'm also not sure whether I completely grasped your question.
My question is, yeah, I mean, in a layman terminology, so we have a questionnaire. We are now calling it like a pain catastrophizing scale. We are giving it some number. We are saying that, okay, now this patient is suffering more or less and so on, right? And from your studies, now we know that we are not actually measuring real catastrophizing. We may not be measuring the real one, but it might be pain variance, pain intensity, and so on, right? If I got it
Yes,
correct.
indeed.
Yes.
Yeah.
Yes.
Yeah. We measure different constructs than intended to assess. But if you, I think one thing, if you want to assess pain catastrophizing, it's not possible to do it via a questionnaire, or at least you should take into account context, because exaggeration means that it's more than it should be, and that you can only say that it's more than it should be if you take into account context, and that is probably something you can do as a clinician if you take into account context, or if you can do while having an interview while taking into account context. But having just a question in general, well, it's very difficult. For example, if you have someone who just got a cancer diagnosis, it's very normal for this person to react very heavily on this, very, very negative. Oh, I will die, or this things might happen very normally. And that could be as expected. But if that would happen with someone who just bumped his stone, for example, well, that would be something that's very exaggerated. So I think context is really important to talk about pain catastrophizing.
Very well put. Yeah. Thank you so much, Dimitri. So we have last 5 minutes. Participants, please feel free to ask your question. We have time for last question if you have any. Or yeah, shall we have a concluding remarks? Any of you want to have? Luis, Daniel, Dimitri? Want to add anything?
Daniel still had a question, but at least he raised his hand for a moment. But
yes,
maybe it's too long for 5 minutes, but I would like to see your take on. There were some attempts to try to dissect suffering from pain, which is very interesting. And sometimes with my clinical cap, I have the impression that many questionnaires are measuring something related to suffering. Of course, suffering may be part of pain, vice versa, but there were some specific attempts. And I remember in Boston, there were some workshops on trying to assess specifically suffering as a different construct when assessing patients with pain. I'd like to know if you how this idea seemed to you guys.
Yeah, sorry, I have some noise here in the background. Sorry for that. I'm not very familiar with this type of questionnaires, to be honest. But I think, and I would think it's very difficult to disentangle them, to be honest, also. Because if you just look at the definition, they're very entangled with each other. You could try to ask very specific about experience and about unpleasantness to try to separate them, but I think it's very difficult, to be honest. Yeah, I think they're highly interrelated. If I see my own research where we try to have both questions, you see they're very highly interrelated. Not always very that high, but most often. Yeah. So
yes,
yeah.
it would be magnificent if we could strip away the two. I agree that it's probably an impossible task. I remember a statement from, I don't think it was Loesser, who said that is suffering and not pain, which takes the patient to the doctor's consultancy, which is probably true in many cases. But catastrophizing is something that we have created as a concept. It can be defined. Suffering, how do you define suffering? So to deconstruct something, to separate things, you first need to have a very clear definition of their borders, and which is the border between pain and suffering. I don't think there is a border, but at the same time, Daniel is right. There are patients with enormous intensity of pain who do not suffer much because other cases. So we know that the two things can be dissociated. But if I had to think about some conclusion that gathers what we have been discussed on, is that it's evident that we can assess pain patients, that this can be useful. We cannot determine or instrumentalize pain. We are assessing essentially things that are related to pain, that can be very important for pain because they can modulate it, amplify, they can guide us to one treatment or another. We can use these markers to define which is neuropathic from non-neuropathic, nociplastic from nociceptive. These are, of course, useful, but we are defining things that are around pain, that contribute to pain. We are not at all identifying objectively pain, which will remain ever a subjective, a private sensation. So I think it is important to accept that, to accept this. We cannot define pain as we cannot really define hunger. What is being hungry? Okay. So if we can be of help to our patients just by constructing things around pain that help us to make a benefit in their lives, we are happy.
Yeah, and maybe one thing I could add to that is what I do think is important to also distinguish between pain experience and interference, because it might not only be suffering, but might also how much it interferes with their daily life that actually brings them to the doctor as well. And I think if you can make that distinction, if you can have a low level of interference despite pain, that this is probably also something that we need to distinguish between. Absolutely. And if I look at my own research on cognitive biases, there you see that despite pain, if people are far less attentive to pain, well, they have also less interference. And I think that could also be a way to look at. So try to distinguish between pain experience and the level of interference that they have.
Perfect. Thank you so much for that lively discussion. So we just made it to the 5 p.m. So yeah, I thank all the panelists again for your time and for your valuable inputs. I'm sure participants have got the answer to the questions they had. So we look forward to the next session. Thank you so much. It's time to close the webinar. Have a nice rest
Thank
of the
you.
evening.
Thanks to you. Bye bye.
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 Ciao, friends.
Luis.